So the treatment was very simple, very straightforward. I'm taking the foam out from underneath the lower sacrum. And this is, he was laying there with hips and knees flexed comfortably. Let's have you lie on your stomach now. And I forgot to show you how the body compensates. The body will always compensate at a distal site when there's a lower body movement dysfunction, positional dysfunction, postural dysfunction. And what we found was in his upper rib cage on the left, he had blocked mobility at rib number 3 and 4. And this is now much freer. So I'm assuming that the sacral torsion has resolved. Here's his ILAs. So the left lower quadrant of the sacrum is right here. And now I spring it and I see his shoulders move, his whole upper body moves. I see his legs move as well. So the force is going through the sacroiliac joints, through the lumbar spine, up and down through the hip joints and down into the lower extremity. And in terms of the side bending, and you can come over and film from the side. And I think that before, I think the camera angle was able to show that my left thumb was higher. And I'm on that lower sacrum now and the thumbs are equal. My thumbnails are abutting each other. And he was lower and he is now symmetrical under the ILA. I can easily move it. Can you see his upper body moving? So the force is able to translate through the sacroiliac, through the lumbar spine, and on up through the whole body. So he's no longer side bent. And now when I palpate this sacrotuberous ligament, it's right there, I'm now able to indent it a little bit. So it's not as tight as it was from that prior side bending. And so now we're going to go up to L5. So this is the PS, this is his PSISs right here. And so that would be a thumb width up from that would be S1, the upper part of the sacrum. And then we would be at L5. And I'm on the outside of the right, on the right side of his spinous process. And now I can spring it and his whole body moves. So now the movement isn't blocked there. He's no longer rotated at L5. So this is a nice example of I'm going to call it a significant sacral torsion for the simple fact that it was apparent in prone line, whereas most of the time they're not observed in prone. If the client has one, it's seen in a sitting flexed lumbar spine. And I think we also demonstrated how the L5 segment is also involved with a movement dysfunction. And that treatment is very straightforward. He's now independent. He doesn't need to keep seeing me. I don't think it's going to twist again, but if he should re-injure it in the same way, he knows how to treat it, and he can do that self-treatment for 2 minutes 3 times a week for a couple of weeks just to reinforce the self-treatment. It's not enough force to make it go the other way. Okay, so we don't have to worry about that. So his self-management for this component of the injury is very straightforward. Thank you very much.